Hello, my name is Dr. Barbara Molosky. I'm a medical oncologist, and I treat only thoracic malignancies, and I've treated my fair share of small cell lung carcinomas. And, it's a real changing world. We now have first line treatment, and we have options in the second line. And today I'm joined by Dr. Sonia Amin Thomas, who's a clinical oncology specialist pharmacist at the Wellstar North Fulton Hospital, Northwest Georgia Oncology Center in Roswell, Georgia. And we're going to talk about the current sort of second line choices and options for our patients. So Sonia, I think you have a case that you're going to present.
Thank you, Dr. Molosky, for the introduction. Those of you may not know, as my role with it as an oncology pharmacist, I work with the oncologists and, choosing treatment and helping with managing side effects. I'm very excited to present this case to you guys. So we had a 62-year-old man who had extensive stage small cell lung cancer. And he came in, with the typical 2-pack per day history of smoking, and he got the first-line treatment of atezolizumab carbonatopoide, and we followed it with maintenance atezolizumab. And then he came back, he presented about 5 months later where he had also progressed. And, he did have a very good performance status. So that was opened up a lot more options for his treatment. So today we're going to kind of discuss what would be a good choice for somebody who, has progressed after 5 months of maintenance first-line treatment, and how to select this treatment option.
A very interesting case, and really, this is very typical. It's the bread and butter of what we see in extensive stage small cell. And whether you're using, the Empire 133 atezolizumab or the Caspian durvalumab, both treatment regimens, patients do progress. And then, I think what's interesting is we sort of have to say, are they platinum sensitive or platinum resistant? And Sonia, how do you, in your center, how do you define that? Because every center is slightly different.
Yes. So we do follow kind of the traditional 6-month rule. And if they progress, less than 6 months after completion of treatment, then they are considered resistant. And if it's greater than 6 months, then they're sensitive. And then we, of course, follow also if they are sensitive, then we would re-challenge with the platinum. But if they're not, then we have, like this case, where we would go through some other treatment options.
Yeah, no, this gentleman is 5 months, so almost at 6 months. So it's kind of an interesting case. Do you call him platinum sensitive or platinum resistant? In my own center, we actually use 3 months. So I think there might be a little bit different, center to center. But what do you think? Would this patient be defined in your center as platinum resistant?
So although technically what by book definition would be resistant, in somebody, in this case, with being, good performance status, having relatively good response to therapy, for small cell lung cancer, 5 months is, not bad at all. Mm-hmm. So, it wouldn't be unheard of to re-challenge with a platinum-based treatment, especially if he's able to tolerate with his performance status. I think it's a very reasonable option.
Yeah, this gentleman sort of sitting on that fence. And, sometimes when I'm faced with patients like this, and I know they're, if he was 6 months platinum sensitive, one of the options is to go to new therapies like lurbinectedin, because I know that the further he's away from platinum, probably the higher the response rate will be when we re-challenge him. So I think in my own practice, sometimes a break from platinum. So, what are our choices in second line? I sort of think of it as lurbinectedin, topotecan, which is got an FDA approval 20 years ago, maybe even 30 years ago, and then CAV. CAV, of course, stands for cyclophosphamide, adriamycin, and vincristine. And if you look at those three regimens, and I've used all three, topotecan is a very hard drug, and mostly because of the thrombocytopenia, and most patients just get so fatigued on it. And if you give it intravenous, it's 5 days. So that's 5 days of a chair time in a chemotherapy unit. CAV, nausea and vomiting from the anthracycline. and you lose your hair. So I'm not a big fan of CAV either. And lurbinectedin, I think, is the easiest of the three. It has some toxicity and some myelosuppression as well, but certainly not to the effect of topotecan. What do you think, Sonia? What do you sort of think of the three different choices?
Yes, so actually I was first going to kind of address the maintenance, since he did progress on maintenance, immunotherapy. In our practice, we don't typically switch over to a different agent, but I don't know in your practice if you guys do consider switching to a different immunotherapy for maintenance or not. I was just curious on what you guys follow.
It's very interesting. I think if you're progressing on a checkpoint inhibitor, that's really telling you that you're resistant to that checkpoint inhibitor and you should stop it and switch. I know sometimes in different parts of the world, drugs are added to the immunotherapy drug, but I'll just say, in my opinion, if you're progressing on a checkpoint inhibitor, adding anything to it, I don't think is going to change the work of that checkpoint inhibitor.
Yes. Okay. Yes. No, I agree. I agree. We would kind of follow the same thing. And I agree with you. I feel like lurbinectedin is probably the best choice for this patient. I know these options on here, but I know they're listed as like using single agent irinotecan or even single agent etoposide. And I feel like it could be considered, but I know for us, like we would still prefer to use lurbinectedin just because, unless there were contraindications to it, that would kind of be our go-to choice. Again, mainly because of the side effects and the response rate with it as well.
Oh, I think you're right. My pharmacists are always bugging me, and rightly so, to really watch out for toxicity and LFTs, especially on immunotherapy. So that's a big one. And we forget that transaminitis is quite common side effect of all checkpoint inhibitors. So I think once you get to second line for small cell lung carcinoma, those same principles apply. We don't want to do any harm. We want to make sure that our patients stay in the best health so that they can even get third line. If this patient goes to lurbinectedin, I would re-challenge him third line with the platinum doublet. These are in these young patients, I find them very patient. I find small cell patients actually quite treatment seeking, especially at a young age. And mostly because they get treatment, they feel better. And then when their disease progresses, they want to feel better again. And that can only be with a drug that has a response rate to it.
No, I agree. And I feel like the challenge, especially with extensive small cell lung cancer, I feel like sometimes the challenge is finding that fine line of, like you mentioned, getting on your case sort of about the toxicities, but still finding that fine line of treating the patient with the cancer being a little more aggressive and being a little more important to treat than kind of worrying about the toxicities as much. Sometimes it's hard to find that fine line and how much to decrease and that sort of stuff. I know we always kind of have a battle with that and what to do.
Oh, for sure. No, for sure. Well, there are some really interesting new combinations and new medications and, challenging our targeting therapy for small cell lung carcinoma. And I'm just going to mention a couple of them. And, again, all of these are in the works. Some of them are phase 2 trials. Some of them are phase 3. What I think is probably the most interesting of the PARP inhibitors, we're starting to learn that these may have a role in small cell lung carcinoma, especially with a biomarker called SLFN11. And that's a bit of a mouthful, but I think the PARP inhibitors are going to work their way into small cell lung carcinoma. Both Pembro and Nivo are being still looked at in this setting with or without lurbinectedin. And of course, antibody drug conjugates, I lived through the DLL3 or Rova-T world where that wasn't effective, but I don't think we're giving up. I think DLL3 is still a really important target for small cell lung carcinoma. Sonia, do you have anything to add? Have you seen in your center, are there any of the trials being looked at for small cell in your center?
So we have not been doing any of the trials at our center, but I know any of these, I think the immunotherapy agents are great. The PARP inhibitors also, I see, they've also been used in a lot of different types of cancers. And I think with small cell, they're really going to play a big, big role, especially the ease of having it be another oral option, right? We talked about, topotecan not being as great, or etoposide not being used as much. So I think it's great to have that oral option. I think immunotherapy and oral chemo will one day take over the world.
One of the most exciting trials, and we contemplated doing it, and I'm not sure if we've made a final decision, but it's the, patients are on platinum doublet with the atezolizumab, and when they go on the atezolizumab maintenance, lubiractinib is added as well, and that's a phase 3 trial, the IMFORT. So to me, that's a really interesting trial, and it's almost like introducing second-line therapy early. It's called maintenance, but it's really introducing a second line early on. And I think that's going to be a fascinating trial as well.
Yes, well, thank you. I look forward to hearing about it, hopefully at ASCO.
Yeah. Well, thank you so much, Sonia, for your case and your insight and a great conversation.
Thank you.
Hello, my name is Barbara Molosky. I'm a medical oncologist, and I treat only thoracic malignancies. And so I'm not going to say how long I've been a medical oncologist for, except to say that I've seen and treated many patients with small cell. Now, immunotherapy has really made finally a break into our treatment, because the chemotherapy that I used when I first graduated as a medical oncologist is the same I'm using now. So immunotherapy has really made its way. But today's conversation, and I'm going to introduce Dr. Christine Argento, is really tailoring treatment choices to the patient, and in the area of relapsed small cell after immunotherapy has failed. So I wanted to introduce my colleague, Dr. Christine Argento, who's a pulmonologist at the Johns Hopkins School of Medicine in Baltimore, Maryland. So welcome, Christine. And
Thank
Christine,
you.
I think you're going to present a case to us.
Yes, I am. So I had a patient recently that I think is a great example of this. So he's a 65-year-old gentleman. He smoked intermittently, as most people do, most of our patients do, for about 40 years. And he's got a history of extensive stage small cell lung cancer with brain metastasis. So he's received to date 2 cycles of atezolizumab, etoposide, and carboplatin. And he presented to the emergency department with chills for about 2 weeks, and then cough and weakness for about a week. When he was seen during his vital signs, he was found to be febrile to 103 degrees, and he had new hypoxia, so new oxygen requirement. He had been on room air before that, and now was requiring 4 liters by nasal cannula. So their initial screening testing, he did a respiratory viral panel, blood cultures that were all negative, and we did a CT angiogram partly to look for pulmonary embolism, which he didn't have. But what we do see is he's got his cancer, but we also see a lot of ground glass opacities that are sort of throughout the lung fields, particularly in the upper lobes, but also extending down into the lower lobes as well. And so this was sort of his initial presentation to us.
And was he, did you biopsy them? Did you do a scope? Did he get a bronchoscopy?
Yeah, so that's a good question. I don't know what you do in your institution. For us, I think if you're concerned that it's pneumonitis and you're pretty sure that's the reason for all of these changes on CT scan, then a biopsy probably isn't necessary. However, if you're not sure if there's lymphangitic spread, if there's infection there, and the patient is stable enough, then they can go for bronchoscopy. In this case, this patient actually ended up rapidly sort of decompensating from a respiratory standpoint. So he went from 4 liters of nasal cannula up to a high flow nasal cannula up to 50 liters per minute of oxygen.
Sure.
And so he ended up being admitted into the ICU. And so he would be considered, this sort of rapidly accelerating, heading towards respiratory failure patient. And so we deemed him to be unsafe as far as a bronchoscopy was concerned. And so what we ended up doing, which I think follows the guidelines pretty much as far as pneumonitis is concerned, is we ended up giving him additional oxygen, starting him on broad spectrum antibiotics. So he got some cefepime, vancomycin. He ended up getting some fluids because he was then a little bit hypotensive. And we decided that he had pneumonia plus or minus a checkpoint inhibitor pneumonitis. And so for that, given that he would technically be considered a grade 4, so, grade 1 pneumonitis would be your asymptomatic patient who might have some changes on their imaging. Grade 2 would be your patient who has imaging findings and is symptomatic, but you can manage them as an outpatient. Grade 3 would be sort of the patient that needs admission to the hospital, and grade 4 would be your life-threatening patient, such as in this case, where they're admitted to the ICU. And so for him, what we did was, again, the antibiotics, and then started him on 2 milligrams per kilogram of methylprednisolone IV. And so we plan to do for him a 6 to 8 week course of steroids, decreasing slowly and tapering over time. And then obviously starting PJP prophylaxis and those kinds of things.
Yeah, it reminds me of a case that I had that, he had quite severe pneumonitis, ended up in the ICU, intubated, and was actually in there for about 2 months. And
Wow.
the ICU guys kept calling me because they thought it was over, but he actually survived it. I kept telling them that, this checkpoint pneumonitis is something that we aggressively treat and can get better. And I'm happy to say that was about a year ago. And he, I just saw him recently, and he's back at work. So I think it's really, if you manage these aggressively, you can actually have a good outcome. Now, in terms of the pneumonitis, I think that's kind of not funny, but I think we sort of throw everything at them. We give them steroids and antibiotics in case we missed, a febrile or a bacterial infection. But again, radiation pneumonitis, a lot of the radiation oncologists, they taper it quite quickly. But I think with immune checkpoint pneumonitis, you really need that slow taper or you'll get in trouble.
Yeah, I feel like every patient that I've treated with an immune checkpoint related pneumonitis ends up relapsing if you taper too quickly.
Exactly. I think that's a great lesson. I think that's a really great lesson. In fact, I remember doing a trial with the atezolizumab, and according to the protocol, it was a 3-month course of steroids. Like it wasn't, 4 weeks or 8 weeks. It's actually 12.
It's so hard on the patient.
Yeah, I know.
They don't like it at all. But I think it's so important. Every time you back off too quickly because you're impatient or the patient is impatient, it backfires and you end up going up higher on steroids.
Christine, in terms of the patient that you presented that had pneumonitis requiring, high dose steroids in a tapering course, would you, once he settled down, start the immune checkpoint inhibitor again, or not, or no?
For me, I would not re-challenge this patient again, just because of the severity of his pneumonitis. So I think if you have a patient with grade 1, grade 2, then a re-challenge is likely to happen. Mm-hmm. But once you get to grade 3 or 4 pneumonitis, I think that's when things get a little dodgy and you really have to think about whether it's safe to do so, because pneumonitis can definitely recur. It recurs in about half of patients. So you really want to be careful, especially those who had really severe symptoms.
Oh, I completely agree. And I think it's also because we have other options for second line. And again, we have CAV, topotecan, lurbinectedin. If you look at the NCCN guidelines, they have a whole other, large amount of therapies, but those are sort of the big three. And, I think you would stop the immunotherapy or the checkpoint inhibitor, get your patient back to, a good quality of life where you can watch them. And when he progresses, he'd be a candidate for second-line therapy.
Exactly. Yeah, that's been our approach as well.
Now, when we diagnose small cell, you get these cytology specimens. It's often done on cytology, these tiny specimens, and then, poof, urgent referral to medical oncology. But there's a lot of work being done into the biomarkers of small cell. It's really been fascinating, starting with RNA expression by Dr. Rudin, followed by, further stereotype or further classifying it by Dr. Gay. And so do you think that we're going to be asking pulmonologists and respirologists to get us bigger samples so we can figure out what the biomarkers are?
I do. I think biomarkers are definitely the way of the future. We see that in non-small cell as well as in small cell carcinomas now. And so most of the time, I would say, biopsying for lung cancer for many patients is really being done by endobronchial ultrasound or EBUS. And those are small FNA samples, just like you mentioned. So they're technically not your core biopsies that we were used to when they were done by radiology, for example. But we have found that, especially with newer technologies, that you're requiring less and less cells, even though we're ordering more and more testing. And our samples have been more than sufficient to be able to detect a lot of these genetic mutations and biomarkers that exist, and they really do guide treatment. So I think it's really important to have that discussion, between the medical oncologist and the respirologist or pulmonologist, just to make sure that those tests all get done up front. They do take time. So even though they're all done, it can delay treatment pretty significantly if you don't order them sort of off the bat. So I think that having that discussion, whether you're going to actually utilize that test or not, is important.
That's excellent. And I'm going to remind the viewers or who's watching is that, there's some really exciting work into, the subtypes of small cell lung carcinoma. And if you get a chance to read the paper by Dr. Gay, it's fascinating where, he took looking at RNA expression and was able to classify small cell into 4 different types. And not only the 4 different types, but perhaps therapeutic drugs that could be used in those 4 different types. And of course, what we all sort of were looking at that, finally a biomarker was being seen as small cell. But I'm going to remind people that this isn't EGFR. It's not plus or minus a mutation. This is expression, and it's a big gray. And certainly from the presentation by Stephen Liu at ASCO 2021, it looks like these subtypes actually might be, at this time, prognostic of a response, not so much predictive of a response. And, you sort of look at these subtypes, A, N, P, I. You would never deny a patient treatment depending on that subtype. So I think it's a really important lesson, and it's exciting because it's going to lead to further work into classification of small cell and hopefully direct treatment. But at the present time, I'm going to remind people that this is far from use today in the clinic. So do you have any last sort of things to say, Christine, about, your role as a pulmonologist looking at patients with extensive stage small cell?
I think this is just a really exciting time. Everything's changing so quickly. For me, it's all about communication with the patient, making sure that they know what to think about, what they know what to look for, communication with your colleagues, medical oncology, radiation oncology, et cetera. I think all of the points that we just talked about, it's a really exciting time. Yeah.
It really is. It's always surprises me, every day I'm ordering a PD-L1 test, and, small cell lung carcinoma, there are these heavy smokers, and yet PD-L1 and TMB don't seem to help us. And it might be that we're not getting a big enough sample. We might be coming back to you and asking you to get more.
Yeah, and I think that's going to be the role now of having a cytopathologist in the room or a tech in the room to make sure that our sample is cellular enough, is giving us adequate, tissue to do all of the testing that's required. Yeah.
Well, that's a great case. I just wanted to thank you for sharing it with us and your expertise. And, again, pneumonitis is something that as a medical oncologist, I dread, but I have a lot of hand holding with people like you, which is really great. So thank you.
Thank you. Thanks for having me.
Hello, my name is Barbara Molosky. I'm a medical oncologist that treats only thoracic malignancies. And today we're going to be talking about small cell lung carcinoma and really optimizing outcomes by improving adverse event management. And I'm happy to be joined by Dr. Victoria Sherry, who's an oncologist nurse practitioner at the Aberson Cancer Center in Pennsylvania, Philadelphia, and also Dr. Sonia Min Thomas, a clinical oncology specialist pharmacist at the WellStar North Fulton Hospital in Northwest Georgia Oncology Center in Roswell, Georgia, USA. And again, welcome you both. I'm going to ask Dr. Victoria Sherry to present a case.
Thank you, Dr. Molosky. Welcome, Dr. Thomas. So for this case study, we have a 61-year-old male with a remote smoking history, approximately 5-pack years. He quit about 30 years ago. He was in a motor vehicle accident where he was hit from behind, and he experienced significant back pain from the impact. He was followed by physical therapy. However, his back pain persisted, and so his primary care provider ordered an MRI of the thoracic and lumbar spine, which showed bone lesions in the lumbar spine and pelvis. He was sent for a CAT scan of the chest, which showed a right upper lobe lung mass. He was seen by pulmonary. He performed a bronchoscopy, which revealed small cell lung cancer. He received palliative radiation to his pelvis for pain control and was started on carboplatin, etoposide, atezolizumab. You see that for 6 cycles. He did well. He went on to receive maintenance atezolizumab. However, a surveillance CAT scan, chest, abdomen, and pelvis 4 months later showed progression in his liver. At that point, he was started on lurbinectedin and underwent RFA to his liver lesion. So he comes back into the clinic 3 weeks later after his first cycle of lurbinectedin with complaints of fatigue, nausea, and constipation.
Yeah, I think that's a great case, mostly because it's so, it's sort of what we see a lot of the times. You know, if you think of the 2 checkpoint inhibitor trials, both Caspian and the Empower 133, most patients did progress by that 4-month time. And lurbinectedin is probably the easiest of our second-line choices, but as your patient, there can be some neurotoxicities. So, I'm going to ask Sonia, what strategies do you think should be done to manage this patient's sort of fever or neutropenia?
Yeah, so great question. You know, these are very typical toxicities that we see, very common to have them. And, for the fever, of course, just monitoring at that point and seeing if there are any sources of infection. And that would sort of be our line to see if we should, treat that inpatient or outpatient. But I think this patient was also complaining more of like the fatigue and nausea and constipation. And I would say, fatigue is definitely number one. It's the main side effect we hear. I know there are some trials out there that kind of looked at fatigue where they mentioned really, I know it's counterintuitive, but walking 10 to 20 minutes a day is really kind of the best for fatigue. So we do recommend patients to walk. We recommend hydration. And not, I think a lot of the patients want to drink like these sort of sports drinks with or B vitamin waters and that sort of stuff. And, I usually tell them it's okay, in moderation, but I usually tell them to really just stick to water because sometimes I don't know how much they're drinking and how much it will impact, electrolytes and other things. So that's typically what I usually tell them. I know with lurbinectedin in the basket trial that they had originally done, I know they looked at some of these side effects where they would decrease the dose on the next round by 12 to 16%. And that fine line of the 12 to 16% is what they found could really help with like efficacy and helping with decreasing side effects. So sometimes we'll play with that as well as the dose reduction for the next time around.
Yeah, I think all of those are great. I chuckled a bit when you said walking, because I just yesterday had a conversation with one of my patients, and I told them that the hardest day to get out of bed is a Monday because you sleep all day Sunday. So, I think patients and even non-patients, they think that exercise is going to decrease their energy, where it actually has been shown to increase it. So I thought your walking, it was a great sort of tip for patients to actually get some exercise and get rid of their fatigue.
In addition, I ask my patients, they can take a cat nap, I say, but I usually don't let them go for more than 1 hour. And I do. As Sonia said, it seems counterintuitive to ask them to exercise, but I do ask, even if it's walking down to their mailbox or walking around the house or doing some form of mild exercise. In severe cases of fatigue, I will add dexamethasone daily, low dose. I don't know if either of you do that in your practice, but I usually reserve that for severe cases.
Yeah, I think it's important, if you use steroids for improving fatigue, that you make sure that there's a limit. Often I see patients who are on steroids for months. Sometimes it's being put on them by the palliative care people, and they live longer than the time period, and then suffer the side effects of long-term steroids. So, but I agree. I think short courses of steroids can really be helpful. Now, do either of you use GCSF for marrow toxicity of any of these drugs?
Yes, I was going to add that in for this patient who has a white blood count of 2,000, ANC of 700. We support all of our patients with pegfilgrastim. And then also I tell my patients to take loratadine, 10 milligrams a day for several days afterwards, just to mitigate some of that bone pain, hopefully.
Interesting.
Yes.
I was on call on the weekend, and a patient on GCSF had severe back pain, and didn't want to take her next dose, and it was a bit challenging. So, but that's a great helpful hint.
Yes, and sort of to echo what Dr. Sherry was saying is same here. We'll tell them even beforehand to the morning of to take loratadine. And sometimes in conjunction with acetaminophen. And then another thing we'll also, I don't know, for you guys, for the pegfilgrastim, we're using the Onpro, the auto body injector. I'm sure that's what you guys are all using, correct? Yeah.
Mm-hmm. Yes.
Yeah. Yeah, it's such a, if you look at NCCN guidelines and you're looking at small cell lung cancer, there's a long list of choices. They all have some myelosuppression to them. I would say, from my own experience, topotecan has the most thrombocytopenia. Lurbinectedin seems to be, I think, the best in terms of the side effect profile. I do come from, again, many years of practice, and so I have used irinotecan, and it may be well tolerated, but I'm not sure there's a lot of activity in it. And again, there's hair loss with many of these agents, including the regimen CAV, the adriamycin, and etoposide, of course, hair loss. So I think they all have some myelosuppression that we have to look out for it. They all have some nausea and vomiting that we have to try to prevent. And of course, make sure that if the patient's of reproductive age, that birth control is being used. So, Dr. Sherry, these are patients, unfortunately, it's palliative, which means we're not going to cure them, and we're giving them many of these therapeutics have side effects. And so how do you, before you start a therapy, of course it's dependent on the therapy you're starting, but what do you sort of warn the patient so that there's no surprises to them?
So I think with a lot of these side effects, as you're going through, I try to focus on being proactive rather than reactive. So we know that they're going to experience, neutropenia. We know that they'll probably experience constipation. And I say, really, however you tolerate your first cycle, you're likely to tolerate it similarly the following cycle. So let's go, it's really the second cycle is very important to me, because I'll look back at the first cycle, see how they tolerated it, and make any tweaks and adjustments according to that. And also, I think, like you said, this is not curable, but treatable, bringing in palliative care very early on. At diagnosis, bringing them into the picture, helping them co-manage everything.
Oh, that's a great idea. I forgot to mention that. And lots of great studies to show that early palliative care referrals can really make a world of difference for patients and their caregivers. Sonia, do you have anything to add to this?
Yes, we always emphasize this, and it's really difficult sometimes for these patients, but really, myself, the pharmacist at our facility, we really actually work with them closely with nutrition and the importance of what they're eating, because we've noticed the patients who are staying healthy throughout the treatment have a lot of support from family. Of course, they do a lot better. And there are studies to kind of show this as well for survival. And so we actually do a lot of education counseling beforehand, before they start these treatments. We're spending about an hour and a half to 2 hours with them, going through and really digging into their lifestyle to figure out how best to help them, instead of just kind of counseling them on the side effects. We kind of look at their diet and help with modifications. And I've noticed that that's really helped, that one-on-one touch. And then coming back, I'll usually go back every time they're there for a cycle and follow up with them and do a session in the infusion center. And I think that kind of one-on-one interaction, sometimes, I know my oncologist doesn't have the resources or the time to really sit there and spend as much time sometimes with the patient. So I think that kind of interaction has really helped with some of the side effects. And just like Dr. Sherry mentioned, just being aware of the side effects and what to do when they actually happen.
Mm-hmm. Sonia, to piggyback off of that, I tell my patients that if they have a side effect, I can typically prescribe a medication for it. But what I can't do for them is exercise, eat, or drink. So I always put that onus on them. And I think we've talked about, the importance of hydration and exercise and nutrition in this discussion.
No, that's excellent. I think I think both of you are so valuable to managing patients as they go through this journey, and to keep them on therapy, because, again, if they respond, not only will their quality of life get better, but they'll live longer. And that's most, patients want that. So you have to have an open discussion. And I think you're right. I think if you can talk to them about what they might be going to expect or might get in terms of a side effect profile, they're probably much more willing to, deal with it and continue therapy. So I wanted to thank you both for your insight and hard work and value to patients with extensive stage small cell.
Thank you. This has been a great discussion.